So Dan, I think you'll need to share your screen again.
That one?
There you
Yep,
go.
perfect.
Okay.
All right. So hello and welcome to the grand rounds for the Minnesota Regional Spinal Cord Injury Model System, or as we call it, MINSCIMS for short. Thank you to everybody for joining us today. MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR, to support innovative projects and research in the delivery, demonstration, and evaluation of medical rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide, please, Dan.
Uh-oh. So why is it not advancing?
There we go. MINSCIMS represents an exciting new partnership among the following institutions: Courage Kenny Rehabilitation Institute in Minneapolis, Mayo Clinic in Rochester, Regents Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, the Paralyzed Veterans of America, the United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical services, acute care services, acute rehabilitation services, and post-acute services. My name is Dr. Kimberly Mondin, and I will be the moderator of today's session. I'm an assistant professor in the Department of Rehabilitation Medicine at the University of Minnesota Medical School and co-project director of the MINSCIMS. So next slide, please, Dan. A few housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the MINSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the raised hand option at the bottom of your Zoom window or using the chat and Q&A functions. We encourage you to raise your hand at the end of Dr. Rohe's presentation today for discussion. If you have technical or logistical questions, we ask that you submit those in the chat to Dan Kelly, who will be monitoring the discussion. We extend a huge thanks to Dan Kelly at the University of Minnesota, who works behind the scenes to make these webinars possible. Next slide. The title of today's presentation is Sexuality and Sexual Function in Spinal Cord Injury, and our speaker today is Dr. Daniel Rohe. Dr. Rohe is a consultant in rehabilitation psychology at the Mayo Clinic with a joint appointment in the departments of psychiatry and psychology and physical medicine and rehabilitation. He's an associate professor of psychology in the Mayo Medical School, and he received his PhD in counseling psychology from the University of Minnesota in 1980. He is board certified in rehabilitation psychology from the American Board of Rehabilitation Psychology, ABRP, and is a fellow of the American Psychological Association. Dr. Rohe's research is focused on personality and vocational interest patterns of persons with traumatic spinal cord injury. He has published in the areas of sexuality and disability, substance abuse and spinal cord injury, and adjustment to disability. For 25 years, he chaired the sexual medicine course in the Mayo Medical School. He is a past president of the Division of Rehabilitation Psychology and served 2 terms on the Council of Representatives of the APA. He is a founding board member and past president of the ABRP. He is the president of the Foundation for Rehabilitation Psychology, a nonprofit whose mission is advancing the psychology of disability and chronic illness. Dr. Rohe, welcome and thank you for presenting.
Thank you, Kim. It's great to be here, and thank you for taking the time to spend your noon hour with us. I want to start by the disclosures, but I particularly want to start with a shout out and a thank you to Lisa Beck, who I think is just on the other side of my office here. And she is a contributor of some of the slides, as well as been a colleague in this endeavor, as well as colleague Dr. Stanley Descharme, who's been a lifelong friend, fellow psychologist, and really a leading figure in the area of SCI, sexual medicine content. So thanks to Lisa and Stan for slides and support for the field and for me. So I have way too many slides, so that one of the reasons to do it this way is to at least get it in the slide deck. We might wind up going skipping over some slides, but because I want to leave about 15 minutes time at the end so we can have some sort of give and take in terms of the audience participation, because that's probably the more valuable part of all of the discussion or the session. The first thing I want to talk about is a shout out to the University of Minnesota and a role that they have played in the whole area and domain of sexual health. And so I'll begin there. And then I'm breaking the presentation down into talking an overview of the clinical practice guideline on sexuality and reproductive health and spinal cord injury. We'll segue into showing and discussing now a 10-year-old video called Feeling Your Way. And it's a Mayo Clinic patient video, and we're going to show about a 5-minute clip. It's the most recent, it's 10 years old, but it's the most recent thing out there and very helpful to make sure that people know it exists. So want to make sure to do that. And if time, we'll talk about the implicit model, but then we're going to shift and have our discussion and then shift on to a group discussion. So let me begin by a little bit of history. And this is particularly kind of fun because this is a Minnesota audience. And so I came to University of Minnesota in 1975, got my degree in 1980 at the U of M. And so the campus and Golden Gophers is near and dear to me. But the history of spinal cord injury, sexuality education really began in the 70s. The program in human sexuality at the U of M started in first with SARS. The University of Minnesota Medical School teamed with, believe it or not, the Lutheran Church, and they put on the first SAR, which is called Sexual Attitude Reassessment. And the whole idea of a SAR is to engage in what's called affective education. And the idea is to become aware of what are your own beliefs and values and the power that has in shaping what you're willing to do or comfortable doing as a clinician. So the SAR started in 1970. That grew to the program in human sexuality, which was primarily research, and then it blossomed into the program in human sexuality. That program now is a world-leading program, and I'm so proud of you for spearheading this. It's now called the Institute of Sexual and Gender Health in the Department of Family Medicine. And Eli Coleman, who was the director, he actually still is, but they now have a new director, Dr. Greta Bauer. So shout out to a wonderful choice of a new director coming in after 30 years of Eli Coleman. So what happened was with the SARS, the two leaders in the field of physical medicine, and many of you, or some of you may know of Ted and Sandra Cole, but this is a picture of Ted, and you can see him looking very Nehru-ish in terms of his outfit from the 70s. But Ted really led the charge in promoting the issue of sexual health in spinal cord injury. And his wife, Sandra, became a sex therapist. And so they sponsored the very first SARS that were disability SARS. And this was an amazing thing to see persons with disabilities coming as a group and being able to talk in a 2-day seminar in which they explored their attitudes, their beliefs, and their sexuality. And you could refer persons there, and it was so amazing. And those things don't exist anymore, as best I know, but it was very, very impactful. So the saga continued in that I came down. There's a younger version of me. I came down to the University of Minnesota, or excuse me, to Mayo Clinic. And with Eli, we established the program, we called it the sexual medicine course at the Mayo Clinic. And that went for 25 years, and we worked in collaboration with the program in human sexuality. So a long-term friend, wonderful person, Eli Coleman. I'm going to segue into discussing clinical practice guideline. It was great to see in the introduction that the Paralyzed Veterans was supporting the efforts of the model systems, because they also have been supportive, provided financial support for a series of clinical practice guidelines covering a variety of topics from bowel and bladder to and a lot of topics in terms of spinal cord injury. Importantly, they had the foresight to say, we really need to deal with the sexuality issue in spinal cord injury. And so in 2010, this clinical practice guideline came out, and it was spearheaded by Stan Ducharme. And then and on top of that, there's also a consumer guide. So at the end, I'll have references. You can go to their website and you can download both the clinician's guide as well as the consumer guide to sexual health. And so, this panel consisted of Stan, 5 physicians, and this is a broad range from urology to physical medicine in terms of representing physicians, as well as 3 psychologists and other team members. So that was the panel. And then they reviewed the literature. This is about 10 years ago, and this is Stan, and he and I were actually had the opportunity to present at the Spinal Cord Injury Center in Delhi. So it was the Indian Spinal Cord Injury Center. And Stan has an amazing vita in terms of international contributions to the field of spinal cord injury rehab. So you can see these are the 8 domains and the 85 recommendations. So I didn't know quite what to do here over a noon hour, how bad this could be. But what I want to do is warning, text slides to follow. And what I'd like you to do as we highlight these is to be thinking about the following, that either as a clinician or a researcher, reflect on your professional setting and what kind of work you're doing and how that relates to the topic of spinal cord injury and sexuality. And so think about these recommendations and think about how many do you actually do, and then how difficult is that to do in your professional space, and then what can we do differently to try to actually bring to fruition the recommendations that have come in, again, 2010. So these are now 12 years old. And my sense is things are getting worse, not better, but I'm curious to see what others think when we get to a discussion. So the first heading is just a basic statement of the importance of sexuality. And so these are the important points, is that as an overall statement, that it's critical to provide access to sexuality education, perhaps using a treatment framework such as the Plicit model, assure that this information is getting to individuals, and also how do you present it? Straightforward, non-judgmental way of going about doing this. But you also have to assess the patient and saying, where are they in their journey with new spinal cord injury, and where were they even before this? So readiness to learn, but yet to encourage them to explore the role of sexuality is another recommendation. But also, really, this is a very delicate topic. And so the issue is, how do you go about providing respect, privacy, and dignity while still trying to achieve your goals? So the first, in terms of sexual history and assessment, so these are the recommendations: to include general questions about sexuality as early as possible in rehab. So I'm curious what people do, especially in acute medical rehab. Inquire about a prior history of trauma. Ensure a medical assessment. Are the physicians actually translating the neurological exam into implications in terms of sexual function? And use, in particular, using the neuromuscular exam to counsel regarding what's physically possible to do, and then actually put together a treatment plan. So that's the recommendations. In terms of education, general considerations of maintaining professional boundaries, being concerned about when did the injury occur. Were they spinal cord injured at age 12, which is a very different experience in terms of their sexual experience compared to somebody who was injured at age 22. And then also a caution, if explicit media are going to be used, is you really have to be careful about the audience. Are they ready to handle this? And do you have care providers available to help the process of assimilating the information? In terms of maintaining sexual well-being, I find these guidelines very interesting. Provide information on methods to enhance sensuality by using all available senses. Provide information on sexual assistive devices. At the end, there's a great reference called Pleasurable, which are a variety of tools that can be used for self or other pleasuring with persons with spinal cord injury, particularly with limited hand function. So a great resource. And then it's also interesting that there's really a recommendation to encourage individuals to expand their sexual repertoire to enhance sexual pleasure following injury. In terms of physical practical considerations, the issue, and we'll talk about this with the film, is to consider bowel and bladder, talk about and educate how to manage bowel and bladder in association with sexual activity, how to prevent skin injury during sexual activity, inspecting skin, educating about optimal positioning for sexual activity, and also educating about risks of autonomic dysreflexia, and also continued risks for sexually transmitted infections and sexually transmitted disease. Additional effects of SCI on function, talk about potential changes in libido, again, exploring alternative parts of the body that might lead to sexual pleasure, potential impact on the injury on arousal, orgasm, and ejaculation, and then educating on masturbation as an okay, giving permission to individuals to have alternative means of expression if that's not part of their sexual experience or repertoire. Treatment of dysfunction, two pieces of this. For males, first of all, education, counseling, and very interesting recommendation of treating erectile dysfunction with least invasive methods first. That is, don't go to the drugs first. See, are there some other ways of achieving erectile function? And then, and you can see, particularly including intracavernosal injection as well as vacuum devices. And then dysfunction from a fertility standpoint, and you can see the issue here in terms of effects on female fertility, as well as effects on male fertility. And so I wonder how much do we actually cover these things during acute medical rehab? I don't think we do, not that I know of here. And but it's also interesting, the recommendation about options for letting people know about how to go about becoming pregnant or assisted fertility. And then lastly, relationship, but not least, is how often do we include the partner when we provide this information to clients, patients on the rehab unit? And the issue is that's critical to do so. They oftentimes are left out because they're not easily available between 8 to 5. How do we accommodate that? And then the issue of actually pointing individuals to, and I thought this was interesting, to meet potential partners for intimate relationships and marriage, and as a recommendation, and then ensure provision of counseling to promote a positive body image, and also discuss options for getting activities of daily living assistance from someone other than the romantic partner to see, because we know what can happen when it kind of degrades a romantic relationship into a brother-sister relationship oftentimes, or so important issues. So those are the highlights as far as that's concerned. I've not been looking at the chat, but if there's anything I need to do, please let me know. So let me slide into Kim. Any issues? Okay.
Nope, no questions so far.
Okay. So let me slide into to keep moving along. So Feeling Your Way is a patient education video, and I got written permission and acknowledgement from the Mayo Clinic to use the video in this presentation. I'm in the process of hopefully getting permission to make this accessible to everybody. But right now, I only have permission for this presentation, but the goal is to make this available. So Feeling Your Way, how we developed this was 10 years ago. It's actually about 2009. The one existing video that was available had significant limitations, and we kept saying we really need a quality made, patient-centric video. And so we went about this task, and again, hats off to Lisa Beck, really leading the charge amongst others. So we put together both a professional and a patient focused groups to say, we think we know what they want to hear, and let's see what people think. And then the second was, what do they want to hear? So talk to the clients. And so we then developed these themes by the professionals, and then we tried to find out what the patients wanted, and then we identified content themes. So we started out with an education planning group to identify content themes. We had a couple physiatrists, a couple rehab nurses, myself, a couple education specialists, as well as the video director, Tom Williams. And we sat down and we came up with content that we thought these are the things that it really would be vital during acute medical rehab to get across to people. And you can see many of these certainly do fit with those clinical practice guidelines. And I can't recall what feminine or male issues were. That's a pretty broad topic, but at least we included dating and relationships. Maybe that might've been me and the nurses. So that was what we came up with. And then but the pivotal message is that we want to make sure to convey in the video from our standpoint was affirming individuals that they are still sexual beings and still a sense of hope about relationships, and but also be able to, there was a balancing act. If you're too explicit, you run risks. And if you're not explicit enough, you run risks. So that was an interesting thing to balance with the video medium. The patient focus groups, there were 2 of them, 90 minutes each, and you can see who were on the, we had 3 and then 5 consumers. And then we then sat in, patient education specialist, video director, and Lisa and I sat in and pulled together this information. And we posed these questions: what's happening currently? What are the most important topics to include? What do you wish you had before you left? At least acute medical rehab. What would you want to tell other patients about sexual health after spinal cord injury? And are there other topics? So these were the things that the consumer group said: how changes in orgasm, how to deal with bowel and bladder, fertility issues, communication skills, new partnering, and being open to being creative is what came out. And these were the themes. But what's fascinating was what the professionals thought was really important in terms of all the nuts and bolts. It really came down to themes of consumers. I remember a quote, it was a person saying, we don't need all the nuts and bolts. We'll figure that out on our own. This is the stuff that we need. So I found that, and I think we all found that sobering to realize how critical this is the message that we needed to get through on the video. So and you can see these are the key messages that we took away from this. And this is the Tom Williams is a award-winning private videographer who regularly does educational videos. He boiled down 32,000 words of discourse from all the stuff that he shot to editing down to 750 words. So it was amazing to see his skills and continue to be amazed. And that's Lisa from the back and talking to him during the filming of this. So this is what the video looks like. It's actually available in a CD. And so at this point, Dan, can you start to roll the video, and we'll watch this for about 5 minutes.
Yep, and if you just want to unmute yourself to let me know when to stop, I'll go ahead and do that.
Okay. Am I unmuted? There we go. No audio.
Yeah, Dan, we have no audio again.
Yeah, let me try.
So,
We even went over this to make sure we had the audio working prior to the presentation, so we apologize.
Yeah,
yeah,
I'm sorry. Let me just keep checking to see.
I don't think anybody's very good at lip reading.
Hold on.
Shopping.
Can you hear now?
And have other people see them and to
Yes.
feel
Yeah.
again like a man and a
Let me
woman.
rewind a little.
Thanks, Dan.
I'll be out with friends or be at a wedding and people will come up to me and will say, "So can you have kids?" And I'll just kind of giggle and they'll be like, "What?" And I'm like, "No, I know your main question is, can you have sex?" you, you don't.
We lost the audio again, I think.
Yeah.
Any other male does. Sexuality and the issue of concerns about sexual health are applicable to individuals no matter what their age, their gender, their sexual preference, their religious background, if you're liberal or you're conservative, your racial background. This is a universal aspect of being human.
I immediately was asked out by people, yet I was really scared. Like I didn't know how it would work. It's scary for a lot of our folks with spinal cord injury to go back out in the community, to go to church services, go shopping, and have other people see them, and to feel again like a man and a woman.
Yeah, I would say nervous, but also like, oh, okay. She wasn't nervous. I was a little nervous, I guess, just to see how things went and stuff. But afterwards, it was fun.
And I started going into the dating websites, and at first I didn't say anything about my injury because I thought, would they accept that? Would I accept it?
The nice thing about the chair, it almost makes things easier for you dating. It weeds out the jerks. Just want things or are shallow or aren't really that good at people. They don't want to date you. Good. See ya.
I learned that there was actually good guys out there.
They really need to have and build that self-confidence. They have to be confident in how they approach people and also be approachable. I honestly was expecting people to come to my dorm room door, knock on it and say, "Want to be my friend?" And I was like, that isn't going to happen, Tasha. Like, if you want to meet people, if you want to have friends, you're going to have to go out. You're going to have to be involved.
I was attracted to her. So I asked her to come help me check the mail, and it just went from there.
I got involved with groups on campus through my major, through music. I joined the choir, and then I started meeting people. Then I started having friends. Oh my gosh, he is so hot. Like every time we would see him, she would always say that. And then he Facebooked me and he goes, "Hey, are you the girl that helped me get the mail?" It's like, he emailed me and then you asked me out on a date. I was pretty shocked. It's exciting.
I can remember the first time that we actually kissed. He was so nervous that he was shaking. And I thought, that's my role. That's usually me.
One time we met up and then I just couldn't shake him with a stick. The next winter,
December, yeah, we moved in together. So
no,
8 months.
the next winter we got engaged.
At the time of my accident in 2006, I was married to my wife, Amanda, and we have my daughter, Ashley, who was 1 year old at that time. The first year, really, I just expected myself to function the way I used to function, and it just wasn't going to happen. And once I got past the point of expecting that, it helped because I started to find other solutions. And within a year or two, I found a solution that really helped us a lot.
The discovery is all about realizing that sexuality is far, far more than the sexual response cycle and the physiology of achieving an orgasm.
Look at other options. Is it all penetration or is it just, touching and kissing and caressing bodies? Still a special connection between you and somebody else. And if they take the time to make you mentally feel wanted and needed, that's still love.
I don't know what your sexual life is going to be like. You've got to invent it. You've got to experiment. You've got to figure out what works and doesn't work for you.
You have to know yourself what you like before anybody else is going to know.
It's really tuning into your senses and finding out what are the feelings going on? What are my sensations? What are the new zones of excitement?
That information really then equips you when you do desire to have a partner to be able to explain to that partner, this is how my body works after spinal cord injury.
My feet are one of the most sensitive things, and you don't give me foot rubs.
I know.
I want to give a foot rub.
Not a big fan
Yeah,
of feet.
feet kind of gross her out. I'll live with it.
Always practicing safe sex techniques is vital.
Not only for sexually transmitted diseases, but also pregnancy.
They may falsely believe, well, since I'm not experiencing orgasm, somehow I don't have to worry about the possibility of pregnancy. Erroneous.
Yes, we are going to have a baby, and I'm 17. I'll be 17 weeks pregnant tomorrow. He wanted to hear it for himself from my doctor that it was okay for me to have a baby. Women that are at the age of becoming pregnant really should consult their obstetrician before considering pregnancy and really have a good communication with their obstetrician, their family provider, and their spinal cord injury provider. I had to figure out how I could be an independent mother. The changing table just has some open spots at the end, so I can get underneath it. The car seat will flip around 180 degrees, so I can put her in straight on and then flip her sideways. There is nothing I can't do. I just have to figure out different ways to do it.
She's 6 years old, and she enjoys soccer and other sports, and I try to participate whatever I can. We still play football. She'll tackle me, and we have lots of fun together. So there's plenty of opportunities to still be a dad and have lots of memories to share.
Dan,
Sexuality
can you go ahead and cut it?
is critical.
Super. So do I need to screen share again?
Yeah.
Awesome. So that's, I think the first 6 minutes, it's a total of 15 minutes. And there's a 8-minute segment and a second chapter that's 7 minutes. And it goes on and talks about a lot of additional things, but you got the feel for what we were trying to address, and you can be the judge about how well we were able to do that on that video. So I'm going to skip the implicit model, and because I think it's far better to move to introducing Kelsey Peterson. And I think, Kim, you're the person to do that.
Yes, I am. Thank you. So as our discussant today, we have Kelsey, who is a dancer, writer, and filmmaker. She received her bachelor's in fine arts and dance from the University of Montana in 2008, and later her yoga teacher certification from Core Power Yoga. Her path took a detour when she sustained a spinal cord injury in 2012 and became paralyzed from the chest down. She now serves as co-director, head choreographer, and dancer on the interabled music and dance production, A Cripple's Dance. As a writer and filmmaker, she finds that her choreographic background lends to the art of storytelling, which she leans on in her documentary film about her journey becoming disabled and finding herself as an artist after her injury. The movie is titled Move Me. Kelsey believes that adaptation and self-love are the keys to liberation and joy as we learn to surrender to the flow of life and reconnect to ourselves, each other, and the present. Kelsey, thank you for joining us today.
Hi, thanks for having me.
Feel free to.
Do you just want me to launch right in?
Yeah, sure, go for it.
Cool. Okay, I can do that. Hi, everybody. It's funny, I'm wearing the same shirt right now that I am in that photo. I'm honored to be here. It was just explained, I was injured 10 years ago. Actually, I just had my 10-year anniversary on the 4th of July. I call it my injureversary. So that was kind of a monumental one. And since then I've done some roles. I was Miss Wheelchair Minnesota. And I got into advocacy through Get Up, Stand Up to Cure Paralysis, actually, one of the sponsors. And now I am a writer for Unite to Fight Paralysis, another sponsor. And they've actually been really supportive in making my film Move Me with my co-director, Daniel Klein. And I started that about 5 years ago. I was at a point, 5 years in where I was still trying to figure out, who I was as a woman with a disability and find myself as an artist again. And those things seemed really far away. Sorry, someone's playing the piano. I'm in a library right now. But I started making this film, and it really started out about driving around the country and sort of getting a picture of the landscape of spinal cord injury research and what was happening in terms of a cure. And it turned out, like, after months of interviewing researchers and different people in the community, that we really didn't have that film. That story wasn't there to be told by what we'd captured. And at the same time, my life was changing really dramatically. So Dr. David Darrow had approached me about, or I'd interviewed him really about his study with electronic stimulation implants. And I was, my dad had just gotten sick, and my friend Gabriel approached me about doing a cripple's dance. And so that was really like the first opportunity for me to return to dance. So I kind of just surrendered to the flow and realized that this was, an opportunity to make a film that was much more vulnerable and much more personal, and really could capture our experience as people with spinal cord injuries and everything we lose, and just the really like multifaceted experience of how our lives change and how it's really like this defining moment, and that we lose a lot of things that define us. And I think that that's like a really big and beautiful thread in the film for me, is that, like, I think a lot of people can relate to losing things in our lives that define us at any given point. We're always, no matter who we are, we have to surrender and adapt, and let go of these things that we thought we'd always have potentially. And a big part of the film for me was being really vulnerable and sharing my sexuality. And that's always been something that I've been proud of and really enjoyed. And I think as a woman and as a person with a disability, those things are oftentimes our rights are taken away or they're not respected, especially in the current political climate. And so it was important for me to be like, hey, this is important to us as a community, as the disability community, as a woman, and to take an opportunity to challenge the status quo and create a bridge between able-bodied and disabled worlds. So my role really now as a person with a disability is to be an advocate in that way and to share this film and bring healing in many different ways to different communities, but especially to the disability community. So yeah, I guess I'm curious, as researchers, how you see, like I noticed when I was on the road that there were, like I had specific conversations that I'm not going to call researchers out, but I had, point blank asked researchers, if you're studying sexual function, are you asking females or, to go beyond the binary, people with vaginas, about their sexual function? And I was met with some disappointing answers sometimes that it really was only, these questions were only being asked to males. And so I'm curious, like, how you see your role as researchers, like, challenging that and how you challenge that, and because it seems like this is really important to you in many ways. And I'm very happy to see that. But I'm curious, like, do you see that this climate being growing in that way?
Kim, are you trying to moderate? Or are we going to go to a larger? Kelsey, can I ask you a question? And that is, do you feel like the clinical practice guidelines, were you happy with what was suggested that should be done prior to people, or as part of the continuum of care, sexual health care to persons with spinal cord injury? Or were they missing things? Or are we even getting close to accomplishing what those guidelines are in the first place?
You mean like when I was in like acute rehab?
Right.
I was actually impressed. I did have an OT that was, I think, like a little more radical, I guess you would say. But for me, that just felt like I just had a lot of gratitude for where she was at with, presenting sexual health and options and just being really open.
Somebody that you can talk to.
Yeah, it just felt like I actually was pleasantly surprised when I worked with someone who was like, hey, let's talk about sex and let's be like, this is a really important part of your holistic health. And it wasn't being swept under the rug. And there have been other times where I felt like it was. So that was really refreshing. And I had male friends there too that appreciated that, I think I got lucky in that way because I don't think a lot of other people in my situation, especially females, had the same experience, I think it could be expanded on for sure. I think after acute rehab, I had to do my own investigating and finding community and other places to expand on my knowledge, and research, rather than it being feeling like the information was coming to me.
When you went for that information, what places did you turn to try to fill those gaps?
God, I don't know. I feel like I went to Mount Sinai. I went to an event there, like in New York. I can't really think of websites off the top of my head, to
Okay.
be honest. Yeah. I think a big part of the story that's missing for me is this really deeper level of self-love that we have to examine as people with disabilities. I think that, you know, like from my own experience, like I was very attached to my body and my abilities and being an able-bodied woman in terms of my sexuality. And so like reframing that and being able to see my body in a loving way and explore it in a loving way was a really key step for me, even being like feeling confident and feeling a sense of like sexual prowess. And I feel like, yeah, you can give people a lot of information and a lot of like tips on what to do and how to do it and blah, 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 blah. But really, like foundationally, people need a way to see themselves in a loving light again, in a sexual light, and to like shift this like ableist view that we all grew up, we weren't born with disabilities, you know, we became disabled. And that's a really huge shift to make. And I think it deserves a lot more care and thought and respect and work, you know, and work for on our own part and assistance doing that work, you know.
Great point.
Yeah, because it's scary to be explorative with yourself and to like redo all that, you know, we did all that self-exploration when we were
Teenagers.
young. Yeah. I mean, for me, I was younger, you know, like I started a little early, but yeah, you know, like we did that already. And so to do that again as adults is like, it can be so exhausting and frustrating and like saddening and maddening. And so it's like, okay, how do we even begin to like explore when maybe we don't even like our bodies, you know?
Dan and Kelsey, there's a comment in the chat. I'll read it out. So one of the participants said, I wonder if some of the barriers are with the individual clinician's level of comfort with whether it is discussed or not.
Right.
Also, in addition to wondering if female sexual health is considered as much as for males, I also wonder how we can better serve the LGBTQ community in this regard. So
100%.
wondering if you guys have any thoughts on that comment.
I mean, yeah, it was definitely apparent to me that, you know, just that video itself is a little antiquated and that it's, you know, all white, straight people. And so like, how do we show up for BIPOC communities and LGBTQ plus communities? You know, can we coordinate events and, you know, really be able to paint a picture of, you know, there's no wrong way to have a body. And so like, how do we really show up for all of these bodies? And it feels like more liberating and safe to be in a space that's diverse, especially like when you become part of a minority group, you know, like I know for me, I feel safer and like I can be more explorative and I feel like more like in a loving space when I, as a person with a disability, am in a space with all different kinds of people.
Great point.
And I do think the first part of your question, which is a great, thank you, which is a great question, is I think for sure there are people that are really uncomfortable with talking about sexuality. And it's like, if you're gonna go into this field and do this research, then like, quite honestly, get over yourself. And like, if you can't ask any type of human being what their experience is like, if you're too scared to ask a person with a vagina, and you're only asking a person with a penis what their experience is like, then find someone else to do the job, you know, like do your role, whatever that may be. But if you're not comfortable doing the whole thing, then you need to outsource and find someone who is, because otherwise you're doing a disservice to the entire community, you know.
And indeed, you know, and that was the purpose of the sexual attitude reassessment program and having training in healthcare programs is to make people aware of their own ableist views of sexuality and disability, but most importantly, make them aware of their own values and how their values affect their comfort level. And so so, because it really comes down to self-awareness of values as a beginning point. And that's really not very well handled in professional programs, and no matter what the specialty might be, is that it's always, kind of a didactic education, knowledge base or skills based, but really doing a deep self look to say, what are my values and beliefs, and how's that going to impact my ability to talk to persons who are different than my values and beliefs. And that's always been the strength of, again, the program at Human and Sexuality at the University of Minnesota, as well as down here. That was focused on physicians, but it's amazing, OTs, PTs. I used to present in the PT school, and it was, I had a 1 hour presentation. And that was canned years ago. They have nothing. And they are the primary providers. As far as I know, they have nothing. They certainly don't have anything that has to do with examining their own values. And yet these are the people that are touching your body day in and day out, and yet can't have a conversation, or at least they're not trained to have a conversation. Many would like to, but they just don't have the comfort level or the skill level. And I just want to emphasize, it's such a huge gap. It's so important, and yet we're so missing the boat in terms of the interdisciplinary team to have those skills on board. You found one OT out of all the possible people. It's like, oh my gosh, it should have been every OT,
Right.
There's a,
Yeah. I think we have to
there's-
not be so scared to get a little weird. Excuse me, sorry.
no, go ahead. Feel free to
Yeah.
finish your thought.
That's really it.
All right, we have another comment, a couple comments in the chat. So the first one for both of you, Dan and Kelsey, especially accounting for the LGBTQIA community, where do we start with a basic level of understanding? We are clearly struggling with a gender normative education. Where and how do you believe we could start? And then Kelsey, there's a specific question for you, which maybe you can put in the chat. People are asking where they can view your documentary.
I will put my website in the chat too, but we're going to be on PBS on November 7th on Independent Lens. And right now we're doing festivals. So if you follow me on Instagram at Move Me Movie, you can stay updated on what festival we're doing next. A lot of them are virtual and in person. So sometimes you'll have the option to watch online. We actually just did Minneapolis St. Paul International Film Festival and got the special jury prize and the audience award. So that was fun, and thanks. And I'm sorry for those of you who missed it, but there will definitely be more opportunities to watch it. Just follow me on the social media platforms and stay tuned. Yeah.
To try to answer that issue of accessing sexual health information for the GLBTI community, it's a great question that I put back to the audience. I'm working with an individual right now who's from the Middle East and who is gay and who's really struggling. And so one of the references that at the end I have is facingdisability.com, and many of you may be familiar with that website. That's kind of one of my go-to websites. But you can only get on their blog if you give them information showing that you actually have a spinal cord injury and where you got your rehab at, and then they'll let you on. So but the issues, I've asked this person to explore that and to just go on the blog and see what are the groups that are out there on Facebook who are in the gay community who are also spinal cord injured. And so that's his most recent homework assignment. So he can educate me as a consumer and a client about where I can turn to and direct other people. But there's a community out there, but the issue is I'm not quite certain how to access that. Any other persons can give comments on that?
Andrew Gurza is a really awesome person to follow as far as a LGBTQ member and a member of the disability community. And I'll put it in the chat too. He's always advocating for queer people and talking about sexuality and disability and queerness. So he's a great resource, and he's just awesome.
We have another comment from one of the participants today who says, as a C4 male quad, I've always felt less than and inadequate to even be in a real relationship, let alone get to that point of this subject after my SCI. Is there a focus on dating advice and self-esteem? I think to clarify, is there a focus on that in the manual and the guidelines that you went over, Dan?
Yeah, there in the clinician, and I read the client version, but going to the guideline, so the consumer guideline from the consortium certainly addresses that. But it tends to be nuts and bolts stuff about this is how the body works, and getting into what Kelsey's talking about, how do you love yourself so you can be loved by someone else, is really not addressed in terms of how do you develop a relationship and how do you respect yourself so that you feel you have something to offer. I don't know how much that's emphasized in anything. So it really takes, I think, other media other than print media to do that, and films like you've done, Kelsey, to help bring out those issues and make them real.
Mm-hmm. I think we lose a lot of our identity, when we're injured, and a lot of our self-worth comes from that, and loving ourselves and feeling like we have purpose. And so, like, for me, finding my identity again and loving myself as this being in this vessel, as a person with a disability, and being able to abstract my idea of who I was as a dancer, and as an artist and as a person, it was huge in terms of me, like, really not just accepting but loving who I am. And my growth and my interest in exploration in my own sexuality since then has exploded.
We have another comment from an OT, kind of reiterating some of the points that you guys have already discussed, saying that they agree that clinician comfort is a factor. As an OT, a big reason that I am pursuing more training in pelvic health topics is because I know that I am one of the providers on my team that is very comfortable talking about these things, but I need more training, more experience, more tools. I'm very comfortable talking about this, but don't have the expertise yet to back up that willingness to discuss these topics with patients.
With time, it gets easier.
All right. Well, thank you. There are some comments in the chat thanking you for this dialogue today. Dan, if you want to advance to the last slide, thank you. So thank you all for attending today's grand rounds. We apologize if not all questions were answered, but please feel free to reach out to Dan Rowe or Kelsey directly if you would like to follow up regarding a question. The recording for the webinar will be posted soon on our SCIMS website. As a reminder, please see the chat for information on how to obtain CME credit for attending today's webinar. And at the end of the webinar, a brief 3-question survey will pop up. We would appreciate your feedback. We also hope you can join us for our next grand rounds. Thank you all for joining and have a great rest of your day.
Thanks, everybody.
Thanks, Kim.
Thank you.
Thanks, Kelsey. And thanks, Dan.
Thanks, Dan. Thank you, Kelsey.
Thank you.